histopathological predictors affecting lymph node status in oral squamous cell carcinoma. So the aim of this study was to analyze the correlation of age, gender, subtypes, and histopathological factors such as tumor grade, depth of invasion, lymphovascular invasion, perinatal invasion, bone invasion, and worst pattern of invasion with cervical lymph node metastasis, extranodal extension, lymph node ratio, number of positive nodes, and T-stage in oral squamous cell carcinoma. But in this presentation, I will mainly be focusing about the correlation of these histopathological factors with the lymph node status. So we conducted a retrospective study on the cases with oral squamous cell carcinoma of all the stages and any designated anatomical subsite of the oral cavity who reported to us from year 2018 to 2023 and who underwent curative intent surgery with or without appropriate adjuvant treatment. Recurrent cases and those who had received neoadjuvant treatment were also included. Patients with histology other than conventional squamous cell carcinoma and those with incomplete medical records of clinical or histopathological details were excluded. While the patients with unresectable oral squamous cell carcinomas, those unfit for surgery, and those who underwent surgery without neck dissection were also excluded. Various clinical pathological parameters were recorded, and their correlation with lymph node metastasis, lymph node ratio, number of positive nodes, extranodal extension, and T stage was analyzed. So, if we talk about the cervical lymph node metastasis, it is one of the most important factors affecting prognosis of the cancers of the oral cavity and is a strong factor in terms of increased recurrence, disease specific, and overall death, associated with up to 50% reduced overall survival and increased metastatic lymph node burden. It also increases the risk of local recurrence and distant metastasis. By lymph node ratio, we understand it is the ratio of the number of positive lymph nodes divided by the total number of lymph nodes excised, regardless of the extent of the neck dissection. Then, of course, the number of positive nodes, we know that it is the total number of positive nodes that we come across. Then, extranodal extension is the tumor growth beyond the capsule of a lymph node that typically presents as a natural, the capsule that typically presents as a natural barrier for tumor progression of metastatic tumor from the lymph nodes into the neck tissues. Extranodal extension can be minor and major. By minor extranodal extension, we mean the extension which is less than or equal to 2 millimeters from the capsule. And extranodal extension major is either the extension that is apparent to the pathologist's naked eye and felt when assessing the surgical specimen, or when it is found more than 2 millimeters beyond the capsule microscopically. It also includes deposits of carcinoma in soft tissues without attendant nodal architecture. Then grade of differentiation based on the Broders criteria, the tumors in a study were graded as well differentiated, moderately differentiated, and poorly differentiated, which are all the variants of conventional squamous cell carcinoma. Depth of invasion, another histopathological factor, was measured from the level of the basement membrane of the closest adjacent normal mucosa, and then a plumb line was drawn from this plane to the deepest point of the tumor invasion as per AJCC 8 edition. The patient cohort was categorized into patients with DOI less than or equal to 5 millimeters, that is D1, then DOI more than 5 millimeters and less than or equal to 10 millimeters, D2, then DOI more than 10 millimeters and less than or equal to 20 millimeters, which was designated as D3, and DOI more than 20 millimeters, which was designated as D4. Then coming to perinatal invasion, it was identified as a nerve being surrounded or infiltrated by the tumor, and it was considered as positive when nerve involvement was present, irrespective of intratumoral or extratumoral and focal or multifocal involvement. In a few studies in the past, we have found that when there is extratumoral perinatal invasion, there is more chances of cervical lymph node metastasis as compared to intratumoral. But in our study, we did not differentiate on the basis of intratumoral or extratumoral. Like any kind of PNI perinatal invasion was there, it was correlated with the lymph node metastasis. Then lymphovascular invasion, it is identified as the tumor invasion within arterial, venous, or lymphatic channels. It was considered as the presence of tumor epithelial cells within or attached to the vascular endothelial lining. Then the bone invasion, the true bone invasion was considered in a study to be present only when there was frank invasion by the tumor cells beyond the cortices of the maxilla and mandible into the medullary spaces grossly and histologically. Then worst pattern of invasion was examined at the host tumor interface, and the one classified by Brandwin, Gensler et al. Was used. The type 1 was the tumor invasion with broad pushing fingers or separate large tumor islands. Sorry, type 1 is the tumor invasion in the broad pushing manner. Type 2 is the tumor invasion with broad pushing fingers or separate large tumor islands with a stellate appearance. It can have a high nuclear grade despite the low grade pattern of invasion. Then type 3 is the invasion islands of tumor greater than 15 cells per island. Type 4 is the uh, invasive tumor islands smaller than 15 cells per island. Then we have the type 5, which is 1 millimeter or greater of the normal tissue between the tumor satellite islands at interface. The patterns 1 to 3 were grouped together as these patterns 1 to 3, they were grouped together as non-infiltrative, while patterns 4 and 5 were grouped as infiltrative. And apart from this, we also correlated the WPI without categorizing them into all these groups. Like all these were correlated separately also. Then we also found the association of the size of the largest cervical metastatic deposit with the lymph node status. Size of the largest cervical metastatic deposit was measured in millimeters. In cases where multiple scattered discontinuous tumor foci were present in a single lymph node, then measurement of the greatest dimension from the foci at one end to the extremely opposite foci, including all the tumor deposits from a single slide, was used as the size of the largest metastatic deposit. Then coming to the statistical analysis, we use univariate regression analysis using Pearson chi-square test to find the association of age, gender, tumor subsite, tumor grade, depth of invasion, perineural invasion, lymphovascular invasion, bone invasion, and burst pattern of invasion with lymph node metastasis, lymph node ratio, positive nodes, extranodal extension, and T stage. Then a reverse operative curve analysis was applied to determine the optimal DOI cutoff value for predicting the increase in the lymph node metastasis, extranodal extension, lymph node ratio, and positive nodes. And also to find the optimal cutoff value of lymph node ratio, positive nodes, number of positive nodes, and size of the largest cervical metastatic deposit for predicting the increase in extranodal extension. How we calculated these cutoff values was by finding the highest sum of sensitivity and specificity. There are many other methods also, like finding the value that is closest to the area under the curve, and many other methods are there. They are very well presented in articles about reverse operative curve by Aldal et al. And Farooq et al., which were published in 2016-17. But in our study, we calculated the DOI cutoff value by summing up the highest sum of sensitivity and specificity. Then all the histopathological predictors that were found to be significant were also entered into the multivariate logistic regression. Then coming to the results, based on the inclusion criteria, 301 patients were enrolled in the study and subjected to further analysis. All these patients were of the age ranging from 22 to 80 years with a mean of 43.94 and a standard deviation of 11.23 years. Buccal mucosa was the most common subsite to be involved by oral squamous cell carcinoma with an incidence of 51.8%, followed by tongue with an incidence of 30% and lower alveolus with an incidence of 9.6%. In most of the Western countries, you see that the tongue is the most common site to be involved by oral squamous cell carcinoma. But in countries of Asia, like especially India, buccal mucosa is most commonly involved because people here generally have the habit of arecanut chewing and other smokeless tobacco use. So buccal mucosa is more common in our country. Then, talking about histopathological predictors of lymph node metastasis, as we can see in this table, we can see all the histopathological predictors have a significant association with the lymph node metastasis. We can see the grade of differentiation. The maximum cases of lymph node metastasis are found in grade 3, followed by grade 1, and then grade 2. So we can see significantly higher number in grade 3. Then depth of invasion, we can see the number of cases with lymph node metastasis is increasing as the depth of invasion is increasing. Again, the same goes for lymphovascular invasion and perineural invasion, where we can see more the cases of lymphovascular invasion, more the cases of perineural invasion, we find significantly more number of cases of lymph node metastasis. Same goes for bone invasion. And if we go to a worse pattern of invasion, we can again see that the number of lymph node metastasis cases are increasing as we are moving towards the advanced grade of worst pattern of invasion. So this is about histopathological predictors of lymph node metastasis, which we got by univariate regression analysis. And we also found the optimal DOI cutoff value for predicting the increase in lymph node metastasis for the subsites overall. And this value, the optimal DOI cutoff value, was found to be 7.75 millimeters for predicting the increase in lymph node metastasis in the subsites overall. And if we talk only about the buccal mucosa, then in this case, the optimal DOI cutoff value was found to be 7.5 millimeters. And you can see both of them were significant. In this also it was significant. And this again, it was significant. Then for the tongue, 6.5 mm was the optimal DOI cutoff value, which was again significant. But for the lower alveolus, we could not find any significant optimal DOI cutoff value. Now, all the histopathological predictors of lymph node metastasis, they were found to be significant on univariate regression analysis. So all of them were also entered into multivariate logistic regression analysis, where we could find that most of them were non-significant. Most of them had non-significant association, but the bone invasion had a significant association with lymph node metastasis. And for depth of invasion, we can see in the cases with DOI less than or equal to 5 millimeters, there was significantly lower number of cases with lymph node metastasis. And so all others had non-significant association. They were not found to be significant. Only depth of invasion, that also DOI less than 5 millimeters, and bone invasion have a significant association after entering it into multivariate logistic regression analysis. Then coming to histopathological predictors of increased lymph node ratio. So with increasing tumor grade, the lymph node ratio was found to increase with a statistically significant association. And lymph node ratio also had a significant association with lymphovascular invasion, perineural invasion, and bone invasion. But there was no significant association with worst pattern of invasion when it was non-categorized. But there was a significant association when it was categorized into infiltrative and non-infiltrative group, that is WPI 1, 2, 3 and WPI 4, 5 groups. And in this, the lymph node ratio was increased in the infiltrative group, that is WPI 4 and 5 group. There was also a significant association of lymph node ratio with increased depth of invasion, and the maximum lymph node ratio was found in cases with D3, that is when the depth of invasion was more than 10 millimeters and less than or equal to 20 millimeters. But again, when we tried to find out the optimal DOI cutoff value, it was not found to be significant. Then coming to histopathological predictors of increased number of positive nodes, there was a significant association of tumor grade with increasing positive nodes from grade 2 to 1. That is, maximum positive nodes were present when there was poorly differentiated carcinoma, followed by grade 1, that is well differentiated, and then the least was present in moderately differentiated. There was also a significant association of a number of positive nodes with lymphovascular invasion, perineural invasion, and bone invasion. There was no significant association with worst pattern of invasion when it was not categorized, but there was again a significant association when it was categorized, and the maximum number of positive nodes were present in the infiltrative group, that is WPI 4 and 5 group. There was a significant association with depth of invasion, which was maximum, where maximum positive nodes were present in cases with D3, that is DOI more than 10 and less than or equal to 20 millimeters. But again, when we tried to find the optimal DOI cutoff value, no significant value could be obtained for predicting the increase in positive nodes also. Then histopathological predictors of extranodal extension. As we can see in this table, that except the grade of differentiation, all the other predictors, that is depth of invasion, lymphovascular invasion, perineural invasion, bone invasion, and worst pattern of invasion, have a significant association with extranodal extension. Then we also try to find the DOI, optimal DOI cutoff value to predict the increase in extranodal extension and for the subsites overall. And this was found to be 7.75 millimeters. And the optimal DOI cutoff value of lymph node ratio for predicting the increase in extranodal extension was 0.026. This is the blue line. This is for the lymph node ratio. We can see for predicting the increase in external extension, the optimal cutoff value of lymph node ratio was 0.03, whereas the optimal cutoff value of number of positive nodes, the green line, the positive nodes, for predicting the increase in external extension, it was 2. That is, if we have 2 or more positive nodes, then the number of then the chances of external extension increases. And then we also found the association of the DOI cutoff value of largest metastatic deposit size. We saw that the 9.5 millimeters was the optimal cutoff value of the largest metastatic deposit size for predicting the increase in extranodal extension. So if the largest metastatic size of 9.5 millimeters or more, then there are significantly higher chances of extranodal extension for cases of oral squamous cell carcinoma. So by all this, we conclude that based on the findings of a study, the tumor grade, depth of invasion, lymphovascular invasion, peritoneal invasion, medullary bone invasion, and worst patterns of invasion are predictors of lymph node metastasis in oral squamous cell carcinoma. Apart from this, they also have a significant association with lymph node ratio and the number of positive nodes. All these variables, excluding the tumor grade, have a significant association with extranodal extension also. So histopathological parameters have a major role to play in determining the lymph node status in oral squamous cell carcinoma patients. So apart from depth of invasion, all other factors, including lymphovascular invasion, peritoneal invasion, medullary bone invasion, and worst pattern of invasion, these should also be included in the staging system. That is the staging system that we have, the TNM staging system, where we are only including the tumor size and depth and the lymph node status. We should also include the lymphovascular invasion, peritoneal invasion, medullary bone invasion, and worst pattern of invasion in this staging system. And also, apart from the presence or absence of lymph node metastasis or external extension, we should also consider the inclusion of lymph node ratio and positive nodes, number of positive nodes in the upcoming staging system for the oral squamous cell carcinoma. And because of the various DOI cutoff values that we got, we should also see that treatment intensification in the form of adjuvant treatment should be considered for squamous cell carcinoma of the tongue when it is DOI more than or equal to 6 millimeters, and for oral squamous cell carcinoma involving buccal mucosa with DOI more than or equal to 7.5 millimeters on account of respective optimal DOI cutoff values obtained in a study. For rest of the subsites that were insufficient in number, more studies with larger number of cases involving these subsites is required. Apart from the presence of lymphovascular invasion, peritoneal invasion, and bone invasion, till now we are considering these 3 factors also for deciding to go for adjuvant treatment. We should also treatment intensification is also required in the presence of WPI 405, because as we saw that in our study, most of the the increased chances of external extension or lymph node status, lymph node metastasis, or increased lymph node ratio or positive nodes were also present in cases of WPI type 405. So we should also consider this as a decision-making tool for adjuvant treatment. And also, if the lymph node ratio is 0.003 or more, or if there are 2 or more positive nodes, or if the size of the largest cervical metastatic deposits is 9.5 or more, we should again go for the adjuvant treatment. Thank you.
The study where we validated a questionnaire. So it's titled Developing and Validating Questionnaire for Knowledge Attitude attitude and practices among caretakers for to reduce this prevalence is to ascertain the existing knowledge, attitude, and practices among the caregivers for children. And there have been many studies which try to do the same. However, there is lack of validated tool for assessing the same, which is relevant in our geographical area, culture, especially in the South India. So this led to the research gap, and we came up with our aim to develop a structured questionnaire on knowledge, attitude, and practices regarding risk factors for otitis media among caretakers of children, and to validate this structured questionnaire on the same. So the methodology is first we did literature search and item generation, followed by expert validation for content and construct validity, reliability, and internal consistency of the questionnaire. So the study had 3 phases. In the first phase, we developed a construct by literature search, and the domain involved was knowledge, attitude, and practices, different questions. So totally we found 12 relevant articles, and 6 of them were from India. We gathered the information, and then we had a focus group discussion of the experts in our field. This is called peer reviewing, and the items in each domain were finalized, bringing up a structured questionnaire. The item generation led to 12 items in knowledge domain, 5 in attitude, and 7 in practice. In the second phase, there was establishment of phase and construct validity, where we took expert opinion. We gave them the questionnaire and a Likert 5-point scale, and the responses were recorded and appreciated. In the second phase, then we did a content validity with the expert validation based on the Likert scale. The items were analyzed, and factors like CVR, CVA, and SCVA, which are content validity index, scale content validity index average, content validity ratio, were calculated. Reliability of a questionnaire was tested using a pilot study and retest using 100 samples. So basically, we gave the questionnaire to 100 of the caregivers, gave them the same questionnaire 4 weeks later, and we sought for the reliability, inter and intra-rated reliability, and calculated Cronbach's alpha coefficient. The results, this is a final version of our questionnaire, containing 12 questions in the knowledge domain. The question started starting with the basic awareness of the symptoms of otitis media to practices, treatment options, management, and the attitude regarding ear diseases that the caregivers had, practices that led to better treatment or prevention. Our results showed that content validity ratio was more than 0.49, which means that none of these questions displayed required any refinement. Item content validity index was 0.78, that none of them need to be excluded. And scale content validity index average was 0.9. That is, on average, all the items can be included in our questionnaire. And in reliability, the Cronbach's alpha value was 0.73, which shows our questionnaire is reliable. So like I said, otitis media could be due to many risk factors, and we need to adequately address these risk factors. Although there are studies that have tried to understand this knowledge, attitude, and practices, they could not provide a validated questionnaire. And we developed this questionnaire, which is suitable in any clinical setup, to identify the areas which need to be addressed and counsel to the caregivers to make our treatment more effective. The limitations of our study are that the practices vary depending upon habits and cultures of local population, and there might be concerns regarding its applicability in other populations that have a lifestyle that is entirely different. So to conclude, our questionnaire will be of good value to all otologists treating otitis media in children in a holistic and effective way. This tool will help design clinical and educational interventions in Indian scenario, and it has satisfactory validity, consistency, and reliability. Thank you.
Study, which is titled on incidence of carotid wall irregularities in acute ischemic stroke patients. So this work primarily evaluates the clinical and biochemical risk factors which are linked to carotid abnormalities. So which are actually critical predictors for some acute ischemic stroke. The study was actually carried out at Mada Medical College with over 60 patients to identify actionable insights which could provide early intervention. So let me take you through these findings. At this very outset, the very important question is why focus on carotid wall abnormalities? Because the carotid wall, the abnormality is usually measured through a thickness which is called carotid intima media thickness. And if the thickness is more than 0.9 mm, it is a proven marker for atherosclerosis and future cardiovascular events. And as far as ischemic strokes are concerned, the most common type often stems from carotid artery stenosis. There are some key modifiable risk factors which I would like to highlight, which include dyslipidemia, hypertension, and smoking. And there are some non-modifiable ones as well, which includes age and male gender. And our study aimed to quantify these associations because qualitatively there is a lot of data, but the quantitative data on this is scarce. And understanding these links can redefine prevention strategies. Moving on to the methodology, it was a cross-sectional study with over 60 acute ischemic stroke patients. It was confirmed by a CT infarct imaging. And participants were adults over 18 years of age, and the exclusion criteria included pregnant women as well as hemorrhagic stroke. So each of the patient underwent a carotid Doppler ultrasound to measure the thickness of the carotid intima media thickness, alongside a lipid profiling ECG, and a complete clinical history was also taken. And sample size was calculated based on the pre-existing prevalence from the prior studies, which was roughly around 2.5%. And this was done to ensure the statistical robustness of this particular study. So data analysis was carried out for continuous variables like cholesterol levels, we did t-test, and for categorical data like smoking, we did chi-square test. So the demographic data, I would call this as the highlight of the study because our cohort had some striking demographics. Patients with carotid abnormalities were significantly older, with a mean age of 64 over 56 in the normal population, and they were predominantly male, like close to 80%. Smoking and hypertension were glaring risk in the study. 70% of smokers had abnormalities versus only 20% of non-smokers. And I would also like to draw the attention to the p-value here, which is 0.0005. And 85% of the hypertensives also showed carotid disease, for which the p-value was again 0.0005. So these numbers clearly underscore the need for targeted screening in this particular group. So moving on to the lipid profile findings, I would like to draw two important observations here. We all know that the lipid profile, if it's going to be deranged, it is a definitive risk factor for stroke because of atherosclerosis. But we had two important striking findings here, which was the total cholesterol level was significantly higher in the abnormality group. It was 175 versus in the normal, it was 150 milligram per deciliter. So surprisingly, the LDL and HDL did not differ significantly. So what I'm trying to explain is that the total cholesterol level is a more reliable marker for carotid risk in this population rather than HDL or LDL levels. And this also aligns with the guidelines for prioritizing total cholesterol in primary prevention, that is by giving an atorvastatin. It is definitely beneficial, and the study reinforces the same. So moving on to the comorbidity profile in the present study. So hypertension dominated the comorbidity profile very clearly. It was close to 60%, and there was often an overlapping with diabetes, but it was 16.67% combined. And there is a triad of hypertension, diabetes, and coronary artery disease, which was seen in 11.67%. So this, although the value is less, there is an amplified risk here, and this reinforces the importance for integrated management, and which is like controlling BP, blood glucose, as well as to mitigate vascular damage. Moving on to the imaging findings in the present study, CT scans showed that the capsuloganglionic region was the most affected. I can give you a value, it is close to 40%, followed by thalamus, which was 25%. But the most important finding here was that, crucially, around 80%, 78.3% of the patients had an abnormal carotid intima media thickness, which was more than 0.9 mm. So this actually mirrors the pre-existing global data. There is no much important or a new finding that we were able to get here. But this also projects an urgency for a Doppler screening in stroke units, domestically at least. I would also like to draw your attention to some key associations in the present study. There are some strong associations here. Total cholesterol level, for example, male gender, age, these are of course non-modifiable. Also hypertension and smoking. All of this had a p-value of less than 0.05. And strikingly, if you could see in the slide, smoking and hypertension, the p-value is 0.0005. Again, I can conclude that if there is a person who's hypertensive male smoker and say he's over 60 years of age with high cholesterol level, then he is very likely to get a carotid wall abnormality and a further ischemic stroke, and he needs attention and immediate targeted intervention. And the roughly it is about 78% chance for a carotid abnormality in such a person. So there are three important takeaways in the present study. First, the total cholesterol level matters more than the HDL or the LDL levels. And the second observation is that the male smokers who are over 60 years of age are high risk. And third, hypertension is the potent modifiable risk factor. If given an option, of course, we want to treat every other modifiable risk factor, but given an option between hypertension and diabetes, hypertension gets the role here. So there are some practical implications as well. So a routine, carotid wall screening for these patients plus an aggressive statin therapy, along with, of course, a smoking cessation program. This could significantly reduce stroke recurrence as well as mortality in these patients. We do understand that there are some limitations for the present study. This was a single center design. So there is a limitation on the generalizability of the result. And as far as the smoking history was concerned, during this study, it was a self-reported smoking history. So there is a potential recall bias in the present study. And it was a large multi-center study. If we could do a large multi-center study in future, we could validate these findings. Despite this, I could assure you of that the data given here is a robust foundation for local practice changes. And there are some conclusions and recommendations here. So in closing, I would like to highlight that the carotid screening in high-risk stroke patients is extremely important, particularly for people who are male and aged over 60 with a history of hypertension and smoking. And mandatory lipid profiles and Doppler ultrasound for stroke admissions is very much important. And tailored interventions for male smokers and hypertensives. I would also like to highlight the importance of long-term studies to go for multi-center studies. Therefore, we can get much more data about this and we can increase the generalizability for the present study. I would also like to take this opportunity to thank our team, particularly Mata Medical College and MediBrains Foundation. And I would also like to highlight that there are no conflicts of interest at the moment. And the ethical committee approval was also obtained in 2023. So thank you very much for patiently.
The introduction sees in the pediatric age group. These bodies are introduced either because the children are very curious to explore the orifices, imitation while playing. Foreign bodies are inserted, or any attention deficit hyperactive disorders are there, and the availability of the objects and the absence of watchful caregivers. These are the risk factors of pediatric foreign bodies. Age of the child and location of foreign body plays a major role in the management, and the variability in the outcome is related to the chemical composition of the foreign body, the shape and dimension of the foreign body, the anatomical site involved in the foreign body. Our main aim, the objective of this is the painless immediate removal of the foreign body. The aim and objective of the study is to analyze foreign bodies in terms of type, site, age, gender distribution, methods of removal, outcomes, and complications. It's a retrospective study done in the Department of Pediatric Otorhinolaryngology at Tertiary Pediatric Hospital. The study population included all patients of age less than 18 years presenting with ENT foreign bodies, lodgement in outpatient department in the ENT or in the ENT emergencies. The total study duration was done of 5 years from January 19 to December 2023. The data was obtained from the ENT clinical registration books and wards, and the following data was obtained regarding the age of the child, gender of the child, type of foreign body, site and side of the foreign body, previous attempts at removal, methods of removal, and outcome and complications. Patients was grouped according to the location of foreign body into nasal, oral, or throat foreign bodies. We have not taken the inhaled foreign bodies into consideration. And for this study, approval was taken from the Institutional Ethics Research Committee. Whenever a patient comes to the OPD or the emergency, thorough history and complete ENT examination was done. Anterior anoscopy performed to diagnose nasal foreign bodies, or rigid and flexible nasal endoscopic examination performed for foreign bodies not visible on anterior anoscopy. Otoscopy employed to diagnose oral foreign bodies, and if sometimes examination under microscope, an additional method for diagnosis and removal of the oral foreign bodies. For swallowed foreign bodies, direct vision obtained with tongue depressor, indirect laryngoscopy performed for cooperative patients, or transnasal flexible endoscopy. Plain X-rays of the neck taken from the patient with history of foreign body ingestion. Total of 920 patients with ENT foreign bodies managed at the ENT department during the period of 19 to 23. In this, around 515 cases are males, around 56%, and around 405 are females, around 44%. Among all the foreign bodies, the most common were the nasal. Around 49% approximately are the foreign bodies present in the nose. Last, the most is the throat foreign bodies, around 7.6% are the throat foreign bodies. If you can see that the major proportion of the foreign body impaction were found in the children between age 2 to 5 years of age group. Around 55% are in the children in the 2 to 5 years of age group, followed by the 5 to 10 years of age group. The foreign bodies were removed without local anesthesia, and in only 12%, around 110 cases, required general anesthesia. This is the diagram showing the chart showing the location of the foreign bodies. This is as I already told you, the gender distribution in the nose, ear, and the throat foreign bodies. Now coming, this is the graph chart showing the distribution of ENT foreign bodies by site, age, gender, and age. As I already told, that the most common age is the 2 to 5 years age group, and the males are more commonly as compared to the females. Methods of removal of foreign body: in 92% cases in nasal foreign body under local anesthesia, in ear around 99% are in local anesthesia, and throat all cases are removed under general anesthesia. Now coming to the results. Total patient, I've already told you, age is the most common. And what is the most common foreign body? In overall, the seeds and the nuts, which are the most common foreign bodies overall. But if you consider the overall foreign bodies, the inorganic foreign bodies are more common as compared to the organic foreign body in both nasal, oral, and throat foreign body. Regarding the clinical presentation, in nasal foreign body, the children present with either the unilateral offensive nasal discharge, epistaxis, rhinitis, or nasal obstruction. In the oral foreign bodies, the most common presentation is otalgia, otorrhea, bleeding from ear, tinnitus, hearing loss, or sense of ear fullness. These are the various 1 or 2 presentation in every child presentation. In the throat foreign bodies, the dysphagia for solids, throat pain, foreign body sensation, odynophagia, or pulling of saliva. It need not all the presentations are there in patients. So in some patient, one is presenting complaint, and other is some other presenting complaint is there. Diagnosis is made in the nasal foreign body by the anterior anoscopy or nasal endoscopy. In oral foreign bodies by otoscopy or examination under microscope, and the throat, the X-ray neck. There is in 50 cases of nasal foreign body, the parents have gone to some other places before coming to our institute for the removal. In 20 cases in the ear foreign bodies, They have gone to some other places. They are either some local doctor or some their previous attempts are done in 20 cases of ear foreign bodies. In the throat, all the patients are come to the hospital. The methods of removal for the nasal foreign body, either we have used hook, drops, probe, or suctioning. The ear foreign bodies, we have the ear scissoring, suctioning, probe, or fine look. And the throat foreign body, the rigid endoscopy is done. In 25 cases of nasal foreign body, there are complications like epistaxis, lacerations of the nasal septum or septal ulcer is there. In the ear foreign bodies, 20 cases have otitis externa or external aortic canal injury is there. In the throat foreign bodies, there is no such complications, but prolonged observation is required in 6 cases of button battery injection or neglected coin where this is there. These are the chart which showing the common types of common foreign bodies in the nose and the age of presentation. So as you can see, the most common foreign body is the seeds and nut, but overall the inorganic foreign bodies are more common as compared to the organic. Same is the oral and same is in the throat foreign bodies. Now this is in some interesting cases which I have done. I just want to show that this is the child which is ingested this lancet of measuring the diabetes. The parents have seen that the child has ingested this foreign body. They tried to remove it with their fingers. Instead of removing, they pushed in the nasopharynx area. You can see that the lancet is present in the nasopharynx and it is stuck to the posterior pharyngeal wall. So we have removed this type of foreign bodies. This is some interesting case I am showing you. This is the foreign body the child has put inside the nose. This is the switch plug or where wire is connected. This is put inside the nose. This is a foreign body in which the child has inserted it's a bangle. As you can see, this is a hook which is attached to the skin of the external aortic canal, so it's not can be removed by just pulling it out. We have taken the patient into general anesthesia and then we have removed it out. This is also a case in this you can see a coin is present in the nasopharynx area. Child has swollen the foreign body coin. The parents have seen that child has swollen the foreign body, so they just try to remove it. Instead of removing, they pushed it to the nasopharynx and stuck in the nasopharynx. So this is removed under general anesthesia. This is also foreign body. This is a key. It comes with some toy, and the child has swallowed this key. As you can see, this is a very uncommon case. The child has swallowed 3 coins, one by one, and all 3 coins are stuck in the cricopharynx area. So we have just removed it. This is our interesting case which has come that while drinking the water from the water bottle, the cap of the water bottle just stuck in the tongue of the child and it's not coming out and the tongue gets swollen. So, and because of the pain, severe pain and ischemia, we are not able to remove it in the local. So we have taken the patient into general anesthesia and then remove it. This is another case. In this, the child has swollen the plastic foreign body, and as you can see, the soft pulse is pushed forward and the foreign body is present in the nasopharynx area. This is another case. In this, child has taken some fish in the dinner and the fish bone is attached with the piercing the tonsil and it's removed under general anesthesia. Now coming to the discussion part, these are the interesting cases which we have done. Foreign bodies account for 11% of cases observed in ENT emergency services. But in our study, because we are pediatric institute, so it constitutes around 30% of all patients examined in ENT emergency are the foreign bodies. So foreign bodies are the most common thing. It represents an emergency problem population, especially in the pediatric age group because of their human and social costs. Younger age group predominance corresponds to their psychomotor development, mouthing activity of children. Why foreign bodies so common in children? Because of these reasons: mouthing activity of children, mimicking the unhealthy habits of ear and nose picking by adults, intellectual and psychological issues. In our study, around 55% of patients are 2 to 5 years of age, and around 30% are 5 to 10 years of age. And right side nasal foreign body is more common due to a right-handedness. Males are more common as compared to females for nasal and oral foreign bodies, but in our study, oral foreign bodies are more common in females. Inorganic are more common as compared to organic foreign bodies. These findings are similar to our study with complication rates between 5 to 6%. This is the coming to the very important thing. Foreign bodies is very risky. This is a button battery foreign bodies in pediatric use. Let me show you. This is a case. In this, the child has swollen a button battery and it's present in the cryptopharynx area, and the chemical leakage is there, and it's charred the upper part of the esophagus. And you can see that there's a stricture formation is also there in the esophagus after when we remove the foreign body. So button battery is very dangerous. Regarding the button batteries, it's because of the increased widespread use in the electronics. If the severe tissue damage occurs due to the sodium hydroxide buildup, discharge batteries also is very harmful. Lithium batteries also causes increased damage. And radiograph, you can see how to differentiate between the button battery and the coin. You can see the double density circular opacity seen in the button batteries as compared to the coin. So if there is the battery size is more than 20 mm, there is increased risk. If the duration is more than 2 hours, then there is increased risk, and the critical time is very less in throat as compared to ear. And the button batteries leads to perforation. That esophageal perforation is less than 2 hours if button battery is present, and the nasal septum is more than 7 hours, then they can cause the nasal septal perforation. The main aim is the quick and safe removal is the key for the button batteries. Now coming to the guidelines for managing foreign bodies in ENT. It should be an interdisciplinary cooperation is very important regarding the managing the foreign bodies. Age, psychosocial factors, nature of foreign bodies, duration, all need to be carefully evaluated. Avoid complications due to removal attempts by amateurs or untrained health professionals. Increase awareness about early diagnosis in all health professionals to reduce morbidity and mortality. Manufacturer guidelines to clearly highlight potential danger for children on label should be present in all toys, and the prevention is the best treatment. Greatest possible attention to be given by parents, babysitters, teachers, and caregivers. Define critical time for each foreign body, route, and nature. The ENT doctor, because of his or her expertise and access to equipment, is in most cases best suited for atraumatic removal of foreign bodies from ear, nose, and mouth, and the upper air digestive tract. To take home messages, permanence of foreign bodies in ENT cavities for over 72 hours or more than 24 hours in the swollen foreign bodies, and repeated attempts to remove the foreign body increases the risk of complication. Detailed medical history and clinical examination is sufficient in most of the cases. Our goal of the treatment should be non-traumatic removal of the foreign body and minimizing reactions, complications caused by the foreign bodies. Thank you.
College, and today I'm here to give a brief talk on the topic top-down modulations in the auditory system, and I hope it will help in interpreting and having a better understanding of the auditory system overall. So to begin with, we know that sound enters the auditory periphery and then it goes all the way up to the auditory cortex via the different nuclei that are present. And this has been commonly called as the feedback, the bottom up or the ascending pathway that is there. But is this enough? Just that the sound get processed for its basic information? Several studies have told that that is not enough, and that there is a descending pathway that starts from the higher levels and goes to the lower levels via the feedback or the top-down pathways, which help modify the signal that is there. So this is a brief, a very simplistic schematic representation of the various connections that are present within the auditory system. And you can see that the solid arrows represent the ascending or the bottom-up pathway, wherein the sound starts moving from the cochlea and it goes all the way up to the auditory cortex. And there are also those dashed lines wherein sound comes, wherein The information or modulations from the higher centers, that is auditory cortex, goes all the way down, even up to the level of the cochlear nucleus. There is also the dotted lines at the bottom of the figure, which shows the olivocochlear bundle, which arises from the superior olivary complex, and it has a role in maintaining the cochlear gain. So all these together is important for auditory processing. So as we've already mentioned, bottom-up processing involves constructing meaningful percepts from sensory information, and the top-down processing is important as it complements the bottom-up process, and it alters the output based on person's existing knowledge, language, and cognition. And overall, the top-down system reshapes the functional circuitry and in turn improves the perception of sounds. So the top-down modulations, it allows prior knowledge, expectations, attention to shape how we perceive and interpret sounds. And the knowledge of what is important and what isn't important is very important to us. That is what shapes how we respond to a particular situation. So it can lead us towards an approach behavior or an avoidance behavior. For example, let's consider a situation where we are in a noisy situation and you hear your name being called from somewhere behind. Now, if you recognize that voice, you know whether you turn and you try talking to them, etc. At the same time, if it is somebody we don't want to really have that conversation with, or we don't it's somebody whom we are having a problem with, we would like to move away from the situation. Or if it is something danger, let's say we are hearing a tiger roar, we want to run away from it. So all that is shaped by the top-down modulations that are present in the auditory system. So there are several methods that can be used to assess these top-down influences, and I've briefly categorized them into three, that is physiological measures, electrophysiological measures, and behavioral measures. So amongst the physiological measures, the most commonly utilized top-down assessment is done using the contralateral suppression of autoacoustic emissions, wherein the amplitude of the autoacoustic emissions is found to be reduced when there is a efferent stimulation or a top-down stimulation activation that is happening. There's also the acoustic reflex. There is contextual modulation, where using the electrophysiological measures, studies have found that depending on the context in which sound is being presented, there is a difference in the response. There is sensory gating, which is otherwise called as a repetitive suppression, wherein when there is redundant information in the auditory system, there is a reduction in the response again, so that the same information does not get coded multiple times. Then there is mismatch negativity, there is electrocochleography, and amongst the behavioral paradigms, people use something called as a forward masking paradigm, wherein the presence of a precursor improves the threshold. Forward masking is nothing but when the sound is masked by another sound that is presented before the actual target sound. So usually when there is the noise presented before the sound, there is a reduction in threshold, but that the reduction is reduced when there is a precursor or an efferent stimulation. So, given the examples of the methods that can be used to study the top-down mechanisms, it is quite evident that most of the mechanisms are inhibitory in nature. And generally, inhibitory networks aid in improving alertness, ignoring irrelevant information, and inhibiting inappropriate response. So, these are quite in line with the goals of the top-down modulations as well. So inhibitory mechanisms and the top-down, or generally the top-down modulations, are important because if there is inappropriate inhibition that is happening, our working memory system can get cluttered, which in turn will reduce the performance efficiency. So these are some of the functions that has been associated with auditory top-down modulations. The first one is fine-tuning of the efferent input. That is, whenever a sound, the basic information of sound reaches the cortex, there is a fine-tuning with information such as the knowledge and other things that existing knowledge and other things that comes into picture, and the fine-tuning happens of the efferent input. It is supposed to improve when the auditory efferent system is activated. Selective attention is supposed to be improved. There's improved sound localization. There is improved perceptual learning. It is also thought to aid in protecting the cochlea. It is, for example, the acoustic reflex that is there. Then it is thought to aid in adverse listening situations, such as conditions such as speech perception and noise, which is a very difficult and a common scenario that we encounter on a daily basis. It helps in detecting if there is something new or if something is repetitive in nature. It helps in sharpening the temporal precision and the tuning of the neurons. It helps in monitoring self-vocalization and also predictive and contextual coding. Predictive coding is, for example, we know, let's say we're hearing sounds, pa, 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 pa. What do you think is the next sound? It is, the tendency is to think that it will be a pa, right? So that is the prediction that is made. Now, when there is a ba that comes instead of a pa, that becomes an error, a predictive error. And then the coding changes. So that predictive and contextual coding is also thought to be mediated by the auditory top-down modulation. So we did a study as part of my doctoral thesis, wherein I assessed the different interactions that are present within the auditory measures. I'm just using this study to give an overview about the complex interactions and the amount of interactions that happen within the auditory system. So over here, we recruited around 72 normal hearing individuals over a wide age range, and measures such as speech perception and noise, working memory, which was assessed using forward digit span, backward digit span, reading span, and operation span. Attention, we specifically measured the attentional inhibition or the conflict resolution ability. Then the medial olivocochlear reflex, which is a top-down influence at the brainstem level, was assessed, and the cortical top-down influence, that is the contextual encoding of speech, wherein how the auditory cortical structures responded to speech in a redundant, that is a repetitive context, or in a novel context, wherein different sounds were presented in the context of the target. Then as an efferent measure, it was acceptable noise levels that was assessed, and other confounds that were considered were age and hearing sensitivity. So a structural equation modeling was used, and you can see the model that is present over here, wherein all these parameters were assessed. The picture looks a little scary, so I'll give a simplified version of it, which is over here. This basically gives all the significant relationships and the near significant relationships, the strong and weak significant relationships that we found in the study. So the study suggests that there is an age effect on the pure tone threshold, the working memory capacity, and the acceptable noise levels. So that is the age effect that was found. Then the significant influencers of speech perception and noise was the working memory capacity and the medial olivocochlear reflex, which is an efferent top-down influence that is there from the level of the brainstem. It originates from the superior olivary complex and goes all the way up till the cochlea. It was measured using contralateral suppression of autoacoustic emissions, as mentioned as one of the methods that can be used. Then the more relevant finding to the current talk is the afferent-efferent connectivity that we observe. For example, contextual index, that CI stands for contextual index, which is the contextual coding of information, that is an efferent mechanism, was found to be associated with the acceptable noise levels, which is an efferent mechanism. Both are at the cortical level. So across the different levels, the afferent and the efferent mechanisms are communicating with each other. Similarly, An association was also found between the medial olivocochlear reflex and the contextual index. So medial olivocochlear reflex is a brainstem efferent mechanism, whereas the contextual index is a cortical efferent mechanism. So at different levels within the auditory system, the efferent mechanisms are communicating with each other. Apart from that, we also found a weak relationship between the attentional inhibition, that is conflict resolution, and working memory capacity. So this is proved to like existing literature which constantly suggests that attention and working memory go hand in hand and they're related to each other. So to summarize the gist of my talk, basically what I wanted to put across was the auditory system interacts in a complex manner with several connections between the afferent, efferent, and even the non-auditory mechanisms such as attention, working memory, etc. And the eventual goal of the auditory system is improved performance. There are top-down modulations, which is a fundamental aspect of auditory perception and which goes hand in hand with bottom-up processing or the afferent processing. Our thoughts, expectations, and goals actively shape how we hear and understand sounds. And it also highlights the brain's remarkable ability to make sense of the auditory sounds that are present around us. So basically what I'm trying to say is that let's not consider perception as a one-way street. It is more of a two-way street wherein there is both bottom-up and top-down processing, and they both interact with each other so that our processing becomes much more efficient, our understanding improves, our perception improves. So there is a lot going on just within the year in order to make us understand what is going on around us. So with this, I come to the end of my talk. I would like to thank the organizing team for reaching out to me with this opportunity. I would like to thank my current institution, that is Manipal Academy of Higher Education, and my alma mater, All India Institute of Speech and Hearing, for giving me the opportunity to grow and learn and explore. And a special mention to my mentor, Dr. Ajit Kumar Upunda, who is a professor at All India Institute of Speech and Hearing. So I am now open for questions.
Sleep and orthodontic relation, basically it's how we treat patients here. The craniofacial malformations or any other malformation related to craniofacial region, it leads to obstructive sleep apnea, and how we can correct it, I'll be dealing that through this presentation. So sleep apnea is basically the cessation of breath during the sleep, and it is mostly related to snoring, upper airway resistance, and other possible causes of resistance or anatomical problems in the nasal cavity or mouth or in the esophagus or pharynx. So obstructive sleep apnea is basically cessation of airflow which is greater than 10 seconds despite continued ventilation, with more than 5 or more episodes per hour. So we'll not go in the detail of obstructive sleep apnea, but rather we'll see how this sleep apnea happens. So the association of sleep depends on various factors, that is the anatomical and functional challenges, basically nasal obstruction, palatal deficiency, maxillary hypoplasia, or muscle dysfunction. And major causes are maxillary constriction. The upper jaw can be narrow, or the lower jaw, the mandible, can be retrognathic, can be placed backward, which leads to obstruction in the airway. So the anatomical factors, apart from those, can be soft tissue factors. There can be inflammation, there can be tongue, which is, having the lower position, the tongue tie can be present. There can be tonsils which are enlarged or inflamed. Then there are some neuromotor dysfunctions or hypotonia. All these factors combine and lead to sleep apnea. However, as I told that there are some soft tissue factors, some hard tissue factors. There can be one possible way which is also related to obstructive sleep apnea is mouth breathing. So because of mouth breathing, some patients will have mouth breathing. It will lead to inflammation of gums, inflammation of tonsils or adenoids, which also causes sleep apnea. So if you see on the left side, this is a normal breathing pattern where the air is flowing, the blue arrow is flowing continuously, while in the middle there is some partial obstruction. This has happened either because of tongue position or because of palate position or some obstruction in the pharynx. On the right corner is the complete obstruction. So as you can see, there is no passage through which air can transfer. So this is the closed throat and open throat, where you can see, if you see the relaxed tongue which is blocking the airway. So tongue has fallen back in this. So sometimes tongue will be so large that it will fall back and it leads to obstruction. So the main part is that craniofacial growth, as a child grows and it reaches adulthood, adolescence or adulthood, there are multiple changes happening in bone structures in the craniofacial region. The anatomy is continuously developing. The bones are developing, getting mature. But during the childbirth or infant, there can be some infections, some rhinitis can be there, adenotonsillar hypertrophies can be there. There can be some maternal factors, some uh, paternal factors. There can be a lot of things which can lead to underdevelopment or maybe development in different directions, which causes sleep apnea. So these leads to craniofacial malformations. These are few syndromes. These are Treacher's Collins syndrome, trisomy 21, macroglossia, enlarged tongue, macrognathia, that is the small lower jaw, mandible, Cruzon syndrome, which I will be talking about. The Perry-Robin syndrome also have cleft defects, cleft lip and palate, and retrognathic mandible. So these are the some photos which I wanted to show. The craniosynostosis, hypoplasia, neoplasia, there can be cleft defects. So these patients, when they come, they already have different uh, uh, bone structures. The mandible is backwardly placed, tongue is differently placed, even the cranial base is having enlarged bone structure, maxilla is backwardly placed or forwardly placed. So these are different patients, and there are some risk factors which are associated with them. These are obesity, presence of structural abnormalities, increasing age, male gender, smoking, alcohol, adenoids, and other things. So the main important factor is to diagnose them, and the diagnosis can be done through imaging modalities, functional diagnostic tools. So these imaging modalities can be of different types. These are so first, before diagnosis, if we got to know that a patient is having sleep apnea, so the gold standard which used to be was the polysomnography, in which the EEG, electroencephalogram, ECG, EMG, these are all recorded. So as soon as patient comes to us, we do this, that is the PSG, polysomnography, and we record tidal volume, respiratory volume, what is the inspiration and expirational volumes, all have been recorded. Then the other part of diagnosis is the airway evaluation. So by opening the mouth, we see if there is any soft tissue inflammation. So these inflammations sometimes lead to blockage of airway. So there are some scores, that is Malampatti score or nasal turbinates, BMI, acoustic reflection, rhinomanometry have to be evaluated for these patients if there is any blockage while doing intraoral examination. So Malampatti score, as you can see here, class 1, 2, 3, 4. So the 4 class is really bad, which is the complete obstruction, and patient cannot breathe during this. The other parameters are pharyngometers or rhinomanometry. Through this, the pharynx or nasal cavity can be examined. The other part of diagnosis is there are some scales, that is sleepiness scales. So Epworth sleepiness scale and pediatric sleep questionnaire is there, which tells us what are the grade. So is there a high chance of getting sleep apneas, or there is moderate chance, or there is no chance. Apart from this, the imaging modalities which I was telling, so we do a 2D lateral cephalogram through which we can evaluate, doing the different analysis, we can evaluate how much constriction is there for airway. So airway passage can be narrow at different positions. It the upper airway can be narrow, the lower airway can also be narrow. So nasopharynx can be narrow or oropharynx can be narrow. So based on these analysis, we come to know that how much constriction is there. Accordingly, we can see what treatment can be done. So now there are 3D airway assessments like CBCTs or CTs are there, which helps us in examining tidal volume, the nasopharyngeal and oropharyngeal narrowest area. These are CBCT, these are 3D examinations. So the volume of the airway can be assessed like this with the lower nasopharynx, velopharynx or oropharynx region. I would say that this slide, which I'm showing now, these are the recent softwares. We at our home, just on our phones, can easily examine the airway, volume of airway, and do the analysis because of these AI development. So these are few softwares which are easily available on phone, and through this we can examine patient, we can scan them, we can have their slides with us, and we can do the airway analysis. These are dolphin imaging, in vivo, Athena, Cephx, ITK Snap, Slicer 3D, Invisilis, Cloud Compare, etc. So there is another modality, that is MRI, which exactly tells us about the soft tissue movement in airway passage. So these are few clinical features which are generally seen with obstructive sleep apnea, that is snoring, xerostomia, diaphoresis, choking or gasping. Daytime symptoms are excessive sleepiness, morning headache, depression, irritability. So there are few differences when OSA is happening in children and in adults. So the daytime hypersomnolosis is there, snoring, nighttime enuresis, cyanosis, cor pulmonale or arrhythmia. So these are basically associated with children, while in adults there is daytime hypersomnolosis, morning headaches, cognitive impairment, depression, obesity and habitual snoring is there. So now after diagnosis and knowing about what is happening to when a child or patient is coming to you with different bone structures, as I told, the maxilla maybe can be backwardly placed or mandible can be backwardly placed. So our aim is to correct not only the airway, to correct the bones, the orthopedic treatment also we have to give them, and do the bone treatment as well. So these are different type of treatment which we do. That is, the for cranial base, we have to maintain the postural correction. Nasal breathing establishment has to be done. For nasomaxillary complex, if arch is narrow, expansion can be done. For mandible, if it is backwardly placed, so different appliances can be given. I will be coming to that. So different appliances can be given to maintain tongue posture and to pull forward mandible. Then there are soft tissue and functional problems. So in that cases, the surgeries have to be done, or the prevention of orofacial inflammations have to be done. So treatment address is the bypass the obstruction, remove soft tissues, do surgical treatment. Which treatment otherwise can be done is behavior, medical or surgical. So this is the first treatment choice, that is the expansion. If you see here, there is a collapsed arch. So because the upper jaw is narrow, the airway is obstructed. So the airway, there is airway turbulence and the air doesn't pass freely through mouth and goes directly to pharynx. So our aim here is to expand the upper arch and to give a good alignment to jaws so air can pass through easily. There are some studies which we do. So here we have done the uh, we have seen the airway constriction, the volume of air before treatment and after treatment. So before treatment, the constriction was seen in the airway. As soon as expansion was done, there was an improvement in the airway. The other appliances which we give for upper jaw, when upper jaw is backwardly placed, as an orthodontist, we try to pull it forward and increase the airway. As you can see here in the radiographs, as well as the appliance you can see here. So this appliance is face mask, which is used to protract, to move forward maxilla. This is one of the study from our department which we have done. So here also we are doing, the patient had come to us with retrographic maxilla, the maxilla was placed backwardly, and then we had placed the face mask to move it forward, and then evaluated the airway. These are few other appliances which we often use, that is mandibular advancement, the tongue retaining device, which allows tongue to place in the forward direction. It does not lead to tongue to go back, fall back in the airway passage. There is another appliance that is called as soft palate or uvula lifting device, that is equalizer. So when there is inflammation in the soft palate or uvula, this appliance, this plate helps us in lifting the palate so the passage is clear for air to go. There are some other procedures, that is surgical procedures, when a patient reaches to adulthood. So then we cannot use few appliances. There we have to go with surgery because bones have fully matured and we cannot do the treatment normally, or we cannot give plates to them. We have to do surgery. So distraction osteogenesis is one of the modalities where we do the segment osteotomy, do the orthognathic surgery and pull forward mandible. Glossectomies can be done if tongue is enlarged. Tonsillectomy, again, if tonsils are hypertrophy, and tracheostomy. However, this is one of the study which we have done. So this deals with the cleft defect in the cleft region. Here you can see there is a palatal defect. Along with that, there is upper jaw is narrow, and we have done the expansion here to improve the airway. Along with that, we have done the ortho treatment to align them. Further, the surgery was done after half orthodontic treatment was done. Once the teeth were aligned, the expansion was done. The surgery was done to pull forward maxilla. So if you see here the comparison of airway, how the airway has improved. The red one is the pre-treatment, yellow is the post-treatment, which was done with expansion and orthodontic treatment, and finally the green one is the improvement in airway after surgery when the maxilla was pushed forward. So these are the recent advances, which is the anterior mandibular positioner. So now we deal with most of the invisible braces, the clear aligners. So clear aligners have taken over the recent technology, and these are some appliances which can be used, that is for mandibular advancement. This has lock and key and invisible appliance. Along with that, these are few other appliances which are made with acrylic and which has push rods. These are intraoral sleep apnea devices or Kravetsky appliance, which is used to pull forward mandible. Then there is innovation, which leads to invisible treatment along with magnets. So these magnets are placed in the invisible appliance, which holds the mandible in a forward direction. Then we have hubs appliance. This is again has push rods which tries to push the lower jaw forward and try to maintain airway. This is the silencer, the silicone positioner, the silicone positioner, which helps again in advancement, and it is a soft appliance which can be worn anytime during the day. This is a silencer appliance and nocturnal airway potency appliance which is used. This has lock and key mechanics which holds both the jaw in a desired position to improve both jaw structures. So initially the traditional therapy for obstructive sleep apnea was to diagnose and to provide continuous positive airway pressure, CPAP. So regularly the airway pressure was given. But nowadays, because of recent trends, recent advancement in orthodontic field as well as in surgical field, so the scenario has changed. The initial thing is to diagnose and see what are the symptoms, at what age patient is coming to you, and then provide the treatment to the bones, teeth, or nasal septum or nasal cavity, and basically to see where is the problem, and then go ahead with the treatment for airway. These are few other articles which shows the innovation. So these can be of different, there are different oral appliances which position mandible forward and also helps in maintaining maxillary structure. This is one white paper which was published in America. So they say that orthodontic treatment is must for obstructed sleep apnea patient, because most of the obstructed sleep apnea cases happen because either upper jaw will be narrow or it will be placed backward, or lower jaw will be so small that it will be placed backward. So orthodontic treatment is must according to them. Another newer appliance which we are working on is a remote controlled mandibular positioner. So these appliances are there which we can control through remote. Instead of putting magnets or instead of putting lock and key to the appliances, nowadays we put sensors to the appliances through which we can track if the patient is wearing appliance, or through which we can advance the bone structures or mandible where we in a desired direction. These are another appliances, the runners appliance. As you can see the intraoral photo on the right side, this is a clear appliance which helps in maintaining both the jaws and move forward the mandible. Another appliance by Invisalign which has wings and which helps us in maintaining the mandible posture. This is aligner sleep apnea appliance. If you see this appliance, this is a recent appliance which we are working. So this appliance has a combined structure which holds maxilla and mandible, but it has a cavity in the center which helps in positioning of the tongue. So it is working on mandible, maxilla as well as on the tongue. So to conclude, I would like to say that the diagnosis of obstructive sleep apnea is important based on at what age the patient is coming to you, and different ages have different treatment modality. For example, if a patient is coming in mixed dentition, so still the jaw bones are growing. During that stage, we can catch hold and we can try pulling forward the bones, whether it is, as I showed, whether it is through mandibular advancement appliances or through face mask therapies or through protracting the maxilla. Once the age is over, that is above 18 years, then along with orthodontic treatment, we have to go with the surgery. The surgical correction of bones have to be done to correct the airway. So thank you very much. This is one of my recent case which we have done. And here the patient had come to us at 16 years of age, which if you see her jaw is backwardly placed. So her airway was also restricted because her jaw was backwardly placed. So we tried to do the orthodontic treatment, and finally with that we had achieved her correction in the face, in jaw bones as well as in the airway. So we had pulled forward the lower jaw. These are my contact details. I would be happy to answer any questions. Thank you very much.
Thank you very much, Doctor, for your presentation.
Extreme pride to publish and to represent my research on this distinguished international platform. I'll be sharing my insights on the topic knowledge, attitude, and practice of guided dentistry among dental personnel, a questionnaire-based survey. To begin with my presentation, breathtaking technological advancements have significantly impacted our lives, ranging from computers to smartphones, from single purpose to multi purpose devices, and the field of medicine and dentistry is no exception to it. Now, the navigation is the most recent technological advancements in both medicine as well as healthcare sciences. This terminology is precisely denoted as guided dentistry in dental treatments. The navigation system was originally introduced in dentistry in United States in 2000 to facilitate the insertion of dental implants. So what is guided dentistry? Dr. David Burgess has very rightly compared guided dentistry or targeted treatment to the global positioning devices installed in our automobiles. It is generally of two types, static and dynamic. In static guided dentistry, the mathematical algorithm of CBCT, that is the DICOM files, are merged with the optical scanner's mathematical algorithm, that is STL, to create the virtual drill path, using which the template or the endodontic guides are fabricated using 3D printing. Whereas in dynamic navigation, it uses optical positioning devices which are controlled by dedicated computerized interface, so it provides a real-time interface displaying the drill into the exact targeted position. What are the advantages of this technique? It reduces the iatrogenic errors, it provides a lot of precision and accuracy, it reduces the duration of treatment and is also minimally invasive. What are its applications? In the field of guided endodontics, implantology, surgery, biopsy, and orthodontics. Now, in the context of ENT, this precision can be crucial in managing conditions like oroenteral communication or when addressing issues related to the insertion of implants in vicinity to maxillary sinus. The oroenteral communication can occur when a communication forms between the mouth and the maxillary sinus, often due to dental procedures or infections. Now, guided surgery, being accurate as well as precise, uses computed tomography or CBCT and can be valuable in the treatment of odontogenic sinusitis. According to an article, a novel nasopharyngeal stent for the treatment of obstructive sleep apnea concluded that the nasopharyngeal stenting widens the range of non-mechanical treatment and seems to be more effective in comparison to the conventional continuous positive airway pressure technique. According to another article by Weldeck S. et al., the guided biopsy was in the treatment of a diagnosis of a osseous pathology in the jawbone, increased the precision and predictability. Also, it was easier to assess the deep-seated locations and to be used in children, and also caused shorter duration of surgical intervention. Now, in an article by Naikar R. et al., it was concluded that the current practice of dentistry should be more towards the digitization in the workflow, and this shift in the digital dentistry can be provided if there are more surveys, dental education programs, and workshops provided to the dental students so that they can provide a more predictable treatment to their patients. Therefore, it can be concluded that surveys are important tools for assessing and understanding treatment approaches and decision-making process. The aim of this study was to conduct a survey to analyze the knowledge, attitude, and practice of the use of guided dentistry and its application among dental students and dental practitioners. Is my screen visible? Hello? Hello? Is my screen visible? Okay, thank you. So the null hypothesis was that there is no difference in the knowledge, attitude, and practice amongst the different dental personnel related to guided dentistry. Moving on to the materials and methods, the study carried out was a descriptive observational study and a web-based electronic survey using Google Forms in which 15 questions related to the attitude and the awareness about the guided dentistry was formulated. The sample size was calculated using the following formula and it was estimated to be around 215. This was the questionnaire form. The link was shared using various digital communication platforms like WhatsApp as well as Gmail accounts to the personal's mobile phones, computers, as well as tablets. Moving on to the results and discussion. A total of 220 dental personnels completed the survey during its study period, which included 43 undergraduates, 58 postgraduates, 47 dental practitioners, and 73 academicians. The very first question asked to the dental personnels were they familiar with the concept of guided dentistry, and do they have any idea of how guided dentistry can be incorporated in their dental practice? It was concluded that amongst all the groups of professional, 100% academicians were aware about the concept of this technique. What was the information source about the guided dentistry application? It was the academic lectures and the electronic media, which were the major sources amongst all the other sources, hence highlighting the importance of the lectures, the education lectures. Also, amongst the undergraduates, the major source of information was via colleagues, so it emphasizes to share the knowledge and work with fellow dentists. The next question asked was that have they ever attended any training programs on guided dentistry? The majority of respondents did not attend any training programs, thus emphasizing to arrange more educational programs for the same. When they were asked to enlist the prerequisites for guided dentistry, as compared to dental practitioners, academicians had more knowledge about the prerequisites, and it was the specialized drills and the 3D printing in which there was lack of knowledge as compared to other prerequisites. When the personals or the professionals were asked about the real-time interface, it was academicians who were more aware about the dynamic navigation system as compared to other dental practitioners. Have they performed guided dentistry in their practice, and if yes, in which clinical scenario? Most of the individuals answered that guided implantology and guided endodontics was the most performed treatment modality. However, there was lack of awareness in relation to guided orthodontics as well as guided surgery. What do they think in the application of guided dentistry in the field of endodontics? Majority of the individuals lack the idea about its usage in fiber post retrieval. Also, academicians were amongst the highest aware group. When they were asked that do they think application of guided dentistry will enhance their clinic practice, majority of the respondents agreed that it will increase their clinical practice. Why do they think guided dentistry is less practiced treatment modality among various dental personnels? Its expensive nature as well as technical difficulty were the most answered responses. And it is in consensus with another article, that is knowledge, attitude and practice of guided endodontics among postgraduate students of endodontics department, a survey which was conducted in the institution of Gujarat, wherein again it was the expensive nature of this technique that was that led to its less usage. Do they think guided dentistry should be included in undergraduate and postgraduate curriculum? Would they prefer to get it treated with guided dentistry modality if ever required? And would they learn more about the guided dentistry in future? The answer was that majority of the respondents reported that guided dentistry should be included in both undergraduate and postgraduate curriculums. Also, majority of the subjects would like themselves to be treated with this treatment modality if and ever required. What, according to them, were the advantages of guided dentistry? It was the minimally invasive nature and its precision and accuracy that were reported as the most significant advantages. The last question was, which source would they prefer to learn more about guided dentistry? And it was the hands-on workshop which was the most preferred source of learning about this novel treatment modality. In conclusion, although guided dentistry offers excellent and predictable treatment options to prevent complications as well as to perform various complicated procedures, most of the people are not aware about this modality is because of its expensive nature. Therefore, with time and more innovations, probably the cost would cut down, making it more affordable treatment modality or strategy for both dentist and patients. It should be aggregated in the curriculum of the postgraduates was one of the keynotes to be included, and academicians were aware more about this treatment as they are involved in more research and attended workshop programs regularly. Electronic media was amongst the major source of information, so we should use this platform judiciously and upload more videos and lectures that can focus mass population. These are the list of my references. Thank you.